Good morning, everybody. We are back for our next show here. I'm sitting here somewhat live with Dr. Sam Jejurikar from Dallas, Texas, whose Instagram handle is at Sam Jejurikar. I'm also sitting with Dr. Sam Rhee of Paramus, New Jersey, whose Instagram handle is at Bergen Cosmetic. And then, of course, myself, I'm Dr. Sal Pacella, La Jolla and San Diego, California, and I'm at San Diego Plastic Surgeon. Welcome, gentlemen. How you doing?
Doing wonderful, Dr. Pacella. How are you this morning?
Very good.
Good. We're fresh off the heels of our last episode talking about the 10 most infamous plastic surgeons, but we're going to shift gears here. I think we need a little breather from that. So today we're going to be talking about a wonderful topic about abdominoplasty, which is an exceptionally common operation we perform as plastic surgeons. Before we get into that and get started, this show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or qualified health provider with any questions that you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something you've seen in the show.
Well, with that, let's transition to talking about tummy tucks. And I think this is going to be an interesting contrast to those of you who watched our last episode. Our last episode was racy and about stereotypes, essentially, in plastic surgery, presenting patients as being unreasonable, vain. But tummy tucks are, and I think you guys would agree with this, far and away one of the most common operations performed in the U.S. and in my practice. I'm sure you guys would agree as well. And the patients that we see fall into basically one of two categories. Women that have had children and whose body has changed and they can't get it back no matter how much they exercise. And then people that have lost massive amounts of weight. These tend to be all people or generally people with very high and realistic expectations, both of which you can meet. Do you guys have any comments before we jump into the meat of this and just sort of your thoughts about tummy tuck and the patients?
I'm glad to be covering this because I do feel like it's a patient population that is extremely satisfied and it makes a dramatic difference.
Yeah, it's a fantastic operation. I'm sure you'll agree that, in New Jersey and in Dallas and in San Diego, moms can be very fit. They can stay active. They can keep their muscle tone. But unfortunately, once the ravages of pregnancy have taken over, it's near impossible to fix that with just simply diet and exercise. And that's where we truly can, I think, give a tremendous amount to our patients. So it is just a fantastic operation.
Well, with that, let's transition to a case presentation. Can you guys see the screen okay here?
Yes.
Perfect. Right. So this is
you should flip to present mode, though.
Thank you.
Slideshow.
Yeah.
There you go.
Thank you, gentlemen. Mm-hmm. So this is a patient that I saw in my practice a couple of years ago, a very typical patient. I think when you look at this patient, she looks like someone who has had two children, and in fact, she was. Someone who is in a good level of physical fitness, but felt as though her body doesn't really match the level of health that she has. More than anything, it was her goal just to try to get back to the look that she had prior to having kids. How would you guys typically evaluate and talk to this sort of patient about what she needs when she walks into your office? Let's start with Sam Rhee about what your approach would be in Paramus.
Thanks, Sam. So in New Jersey, we see a lot of moms. We see a lot of relatively fit moms, and they present exactly the way you mentioned. They don't feel that their appearance matches what their effort or that their attempts at being fit embody. And when I talk to patients about body contouring, I really try to break it down very simply for them. I think about are we addressing primarily fat or are we addressing primarily skin excess? And if there's a lot of skin excess in a patient, something simple like liposuction generally is not going to be a great choice. And so I try to break it down initially with patients on that first consultation about what might be the most appropriate approach for them in terms of what might be most helpful. Sal?
Yeah. So, I think one of the things that I really try to communicate with patients when we're talking about abdominoplasty is, there seems to be a misconception of why a tummy looks like this after pregnancy. And many patients believe that the two muscles on the inside of the abdomen, the rectus abdominis muscles, simply separate and create a bulge called the diastasis. And that happens to some extent. But the other thing that happens is the width of the muscle actually stretches out organically. It's not that you have these two tight bands of muscle and then they just separate during pregnancy. Everything has stretched out over time with pregnancy. So if you were to look at a post-pregnancy rectus abdominis muscle, it's sometimes over twice the size of width than it is pre-pregnancy. So with that, what I tell patients is this is very similar to a bungee cord. If a bungee cord, which is tight right out of the box, is going to stretch back and forth, and that's your abdominal wall before kids. After children, unfortunately, that bungee cord has stretched out and doesn't have the elasticity anymore, and it just simply functions as a rope. There's no elasticity. So when you tighten up the muscles in an active formation, you can make your tummy very thin. But the big problem with post-pregnancy bellies is at rest. There's no way to tighten this up without surgery. So, but looking at this patient, I think, Dr. J in Dallas doing all the plastic surgery you do, this is a wonderful patient who I think would benefit tremendously from a tummy tuck. You can see she's got that laxity of skin down below. She's got some stria. You can probably take a good chunk of that discolored skin out. And overall, if you look at the waistline, she's got a fairly petite waistline, which is very nice. She's got a little bit of hip adiposity, which once that is cleaned up with a little bit of liposuction, she's got a really nice figure. So I think this is going to be a real home run.
Yeah, this is something that diet and exercise alone is not going to be able to address. You can see where her area of focus is, and it's her abdomen. And just like Sal said, this is a patient who would be an excellent candidate for that procedure.
So how do you guys handle the patient that comes in and says, but Dr. Pacella, I live in San Diego. I go to the beach all the time. I don't want to have a scar. Can't you just do liposuction?
Yeah. So good question. That's a very common question we get. So liposuction does very well for patients with fatty tissue in the abdomen or anywhere, but it doesn't do very well with skin that is very thin. Okay. And the reason is that skin doesn't retract. So if you can clearly see from this photograph, if you look at the skin on the love handle area, the lower back, the flank area, that is, even from far away a distance, you can see that skin is thicker. It has good elasticity to it. So liposuction works phenomenally well for areas of the body where the skin is thick and there's good elasticity. And part of the thing we do beforehand to check this out is to simply just do a physical exam and pinch the skin and see what it looks like. That skin, if I were to pinch on the front of the belly, that would just simply hang there. It wouldn't retract back. And that's where liposuction is not going to do a very good job of.
Dr. Rhee?
Yes, that's why I always open with skin versus fat. We know that liposuction works well with fat. In this case, I would counsel the patient that there's a very high likelihood that there would be skin excess and drooping with just a liposuction procedure alone. And that's something I talk to many patients about. Right.
So Dr. Rhee, when you're so in Paramus, obviously you're going to have patients that are wearing bikinis and bathing suits down the shore for most of the summer. Dr. Jejurikar and myself that are in Dallas and San Diego, they're wearing them a few longer times of the year. But tell me a little bit about where that scar is. What do you tell patients when it comes to wearing a bikini bottom or a bathing suit?
That is one of the biggest concerns patients always have. Where is the scar going to be located? And the simplest thing I can say is it's similar in position to a C-section scar, except it extends longer on each side. So depending on how much skin excess there is, it can extend usually to about hip to hip, but it's located in a way such that if you're not going to see your C-section scar, as long as you place that abdominoplasty scar properly, it should also be camouflaged in the same way.
Yeah, Dr. Jejurikar, in your practice in Dallas, where do you place that incision for? Let's say somebody has a C-section scar. Where would you place the incision? Below the C-section scar? Would you try to take it out, or do you go right within the scar? What do you do?
This slide here is from an educational program that I use in my office called Touch MD. I'm not sure if you guys use it as well, but it's I always point out what's wrong with this picture when I show it to patients. So to take a step back, the question I asked about the scar, it is something that so many people have an objection to. And what I generally will tell people is we can't do a lot about the length of the scar that you need for the procedure, but we can do a lot about the location, and we can do a lot about the quality. And so in this picture here, this is sort of drawn, this incision is drawn to fall right below the lower portion of the abdominal wall. But if you think about it, with this operation, you are closing the abdominal wall under some degree of tension. Ultimately, if your skin is loose at the end of a tummy tuck, what was the point of having a tummy tuck? When you have that degree of tension, the scar has a tendency to rise up. So the way I will design my scar is I want it to fall very much in a bikini bottom. So I will, when I mark the patient, actually stretch their abdominal wall skin upwards, meaning that the scar is actually going to fall just 3 or 4 centimeters across the very top of the vulva. It's going to be incredibly low. We're going to err on the side of keeping it low down here. And then as you come across laterally, it's going to go right at the junction of the thigh and the lower portion of the abdominal wall. And by doing that, we can make sure that it really will be hidden in a bathing suit. Every now and then, you'll run across a patient who has a different style of bathing suit. Maybe they'll wear a more high-waisted one, so you have to air the scar upwards. Sometimes people like more of a shorts look to their bikini bottom, so you'll go across. But the key is you can really alter the position of the scar to fit into a bathing suit bottom.
Yeah, that's a great point. Early on when we were residents, we had say plastic surgeons towards their middle age, and I would remember seeing as mentors, and I remember seeing the incisions for the tummy tucks, and they were very high waisted. It's like the sort of 1980s Pamela Anderson type of bikini that kind of rides up the high area here. And, it's important for us, I think, as cosmetic surgeons in our respective parts of the country to understand, the styles that occur in women's bathing wear. I mean, it's not too bad. Not too bad of a process to keep up with that. I think it's, good. Right.
Yeah.
But the bikini bottoms will drift up and down over a span of 6 or 7 years, believe it or not. And so it goes up, it goes down. And the boy shorts have a lower thickness, a lower riding on the hip bone. So it's important for us to keep in mind, as styles change, exactly where we're keeping that scar. And I think, what I try to do is I try to have patients bring in a bikini bottom or a pair of undies that they would usually wear. We'll try to stick that incision right within that. But I always err on the side of trying to keep it right within the crease of the hip.
Yeah. Now talk to me about quality of the scars. What kind of things do you guys do with your patients post-operatively? And over what period of time do you tell them they have to manage their scars after surgery?
So I'll start with scar. You're right. Scar management is one of the most important things, obviously, for abdominoplasty. It's the most visible part of the procedure. I manage scars a very, very long time in patients. I have a fair number of patients who have darker complexions, who tend to have potentially darker scars. And so I am a big proponent of silicone gel sheeting. I am also pretty proactive when it comes to treating scars with either topical cortisone or injectable cortisone, like a Kenalog type of solution if I need to. I think prevention in terms of managing scars is the most important thing.
Yeah. Dr. Pacella, any different strategies you take in the very sunny San Diego?
Yeah. So these scars are a challenge, and I gotta admit that my evolution of scar management has changed throughout my 12 years of practice, and part of that is actually what's done in the operating room. So this is a little bit of a technical issue, but early on in residency, we were taught to close these areas of so there's really 3 layers we have to close. We have to close the deeper fascia called scarpus fascia that prevents the scar from stretching over time. Then we have to close something called the deep dermis, which is the deeper layer of just skin. And then there's the top layer of skin called the epidermis. Okay. And usually that's done in 3 layers. And so, in residency, you both probably remember we would do a lot of interrupted sutures with a type of suture called Vicryl, which is a braided suture. And as I started doing that in practice, I noticed that that causes a lot of inflammation. Braided sutures cause a tremendous amount of inflammation. They can sometimes spit out to the outside world, and that just creates a really bad scar. So I've really tried to minimize the total amount of interrupted sutures that I use. And so I'll just put a strategic couple interrupted sutures in scarpus fascia just to hold position. But then I'll also do a locking running suture from side to side. And that's with a monofilament suture. And what that does is, at least in my practice, I think, it cuts down on the total amount of inflammation. It still is a tight repair of scarpus fascia, but it gets rid of those knots that may spit over time.
Yeah.
I try to do something very similar to the deep dermis and the epidermis to avoid knots internally. So, and I think that's helped 1,000% in the appearance of my scars.
I agree completely with that. I do something very similar. Instead of using a monofilament, this is very technical. I use a braided suture that's avoided not to. I'm sorry, a barb suture that's avoided. That's meant to avoid having any knots in it whatsoever. But I agree that is an excellent technical point. But I think it goes to a bigger picture. It's really important for your surgeon to pay attention to closing all 3 of those layers. Believe it or not, going back to our training, there was actually debate within the plastic surgery community about whether or not you needed to close that deepest layer, scarpus fascia. Many surgeons thought it was unnecessary for closure, but I think almost all plastic surgeons would agree, though I do know some that do not, that if you don't close scarpus fascia, you get the same quality of closure. And I think all of us here would say that if you don't close that deep layer, the scar will widen over time. So the bottom line is, as a patient, it's a great idea to have this conversation with your surgeon. What steps are you going to take to make sure my scar doesn't separate? So I'll talk about these things with my patients. And then I also tell them, particularly in my patients with pigmentation, you need to think about managing your scar for 6 to 12 months after surgery. Most people want to think about their surgery and then sort of be done with it. And within a few weeks, I should move on. But where the scar is concerned, you have to be obsessive about it. So we have a regimen in our practice where we'll use, just like Dr. Rhee mentioned he does in New Jersey, where we'll use silicone-based treatment for up to 6 months afterwards. If there's any signs of there being any darkness, we'll think about adding bleaching creams, adding broadband light therapies. If there's redness, we'll add pulse dilators or fractionated CO2 lasers. But the key is to be proactive all along. And with that, in the vast majority of patients, you can actually get a great result with their scars. Any other technical points you guys want to touch upon before we sort of move on?
No, I love the barbed sutures.
Yeah. Tell me a little bit about your thoughts on progressive tension sutures and drains.
So the plastic surgeon or plastic surgeons that really popularize that are the Pollocks, who are in Dallas, and I know Todd Pollock fairly well. I'm a believer in progressive tension sutures, and for the people that are out there, what they are there sutures that actually go from the undersurface of the skin to the muscle layers right here. And the purpose is that you can actually close off the dead space entirely and avoid potentially using drains. I personally still like using drains, although I use progressive tension sutures in virtually all of my patients. progressive tension sutures do add 15 to 20 minutes to my case, but I do find that drain output tends to be substantially lower, and I don't have to keep drains in for very long. I personally think, though, that using drains in patients after surgery helps their swelling get better faster. One of the things, and one of the things Dr. Pacella touched upon when he was talking about muscle is that you get generalized stretching of the muscle. Well, the same is true with the skin. And if you think about it, one of the reasons we need to have this surgery and have this procedure performed is because patients have lost the elasticity of their skin. So my goal is to get their swelling to go down as quickly as possible after surgery. I think drains are helpful for that. I think lymphatic massage is helpful for that as well. So I use both of those in my practice to try to get the skin to redrape as quickly as possible after surgery.
Yeah. Go ahead.
I do use progressive tension sutures. I think they are helpful. I also think they help to a certain degree with the scar widening as well. You can take some tension off the closure a little bit with that. I also still use drains even with that. I'm a belt and suspenders kind of guy, I guess, with that sort of thing.
Mm-hmm. Yeah. One other technical point about progressive tension sutures that, I like is, if you look at a, really good looking female abdomen, it's not flat. Okay. There's a little bit of just a gentle pooch as you get down lower. Okay. And that's a sign of a really beautiful midsection. The other sign is sort of a reinforcement of the natural abdominis musculature. So what I tend to do is above the belly button, all the way to the notch of the sternum and then down to the pubis, I try to do a little bit of aggressive liposuction in the flap at the midline. And what that does is it sucks out a little bit of fat up and down and creates this little bit of a gully. Okay. One of the surgeons I used to work with, Dr. Grant Stevens, used to call this a champagne line. All right. And yeah, exactly. And so creating that little notch, I think, works really nice because and your progressive tension sutures are done just underneath there, and that causes a little bit of indentation in the central line, and that creates that nice contour to the abdomen. I think that's an important technique to get some appearance. Yeah.
I totally agree. So just touching upon, we talked about a lot of technical points, but for those viewers who just don't understand how the operation works, very quickly going through this diagram right here, imagine that on the top left, you have a pre-pregnancy look. Your surgeon will essentially design an incision that's going to allow them to get access to the abdominal wall. They'll also have to make an incision around the belly button. And the reason for that is the belly button is a closed stalk that's actually attached to your abdominal wall. Once you make this incision, your surgeon can lift all the skin up, see these rectus abdominis muscles that have separated, put sutures back into it to actually bring the abdominal wall back together and to restore integrity. And then there's this maneuver, near the end of the case where the surgeon will actually flex you on the operating table to basically make your skin as loose as possible. And with your skin being loose, they'll remove all of the excess, including the opening where the belly button had been, and then actually create a new opening for the belly button, bring out the belly button, sew it into place, and then do a meticulous closure at the end. And that's what's involved with a tummy tuck. Before I show the post-ops, is there any other steps of the operation or anything else that either you, Dr. Pacella in San Diego, or you, Dr. Rhee in New Jersey, want to add?
I think belly buttons are a big concern for patients, the appearance of that. And I think there are a lot of variety of ways of bringing that umbilical stalk up and creating that new hole for it. So I'm always interested in hearing tips and tricks about that.
Belly buttons, correct me if you guys feel differently, they're at times the bane of my existence. Because if you think about it, what is the belly button? The belly button is it's the remnant of the umbilical stalk, but it's a bunch of scar that's basically formed this indentation with a relatively poor blood supply. And in plastic surgery, you heal your plastic surgery and talking about blood supply all the time. That's how you heal things. You cut all the way around it, so you eliminate the blood supply coming from around it, and then you tighten the muscles aggressively across the bottom of it, so you constrict some of the blood flow going to it. So I generally find that in the first 6 weeks, I have a lot of conversations about belly buttons and how great they don't look in that time. I generally find that they can be a little too small in the beginning. So we'll use maneuvers like a foam earplug to try to open it up. I err on the side of making it too small because it's a lot easier to make a belly button bigger later on than it is to shrink it down in size. But I'll use all absorbable sutures. I'll tack down the belly button at the 3 o'clock, 6 o'clock, 9 o'clock, and 12 o'clock position with sutures that go from the skin all the way down to the muscle to really give an innie look to my patients.
Yeah, it's interesting for our viewers out there and listeners. This is, I think, the sign of a really good plastic surgeon is what these two gentlemen that I'm with today are sort of echoing, which is, we're taught in residency program a certain step of the operation 1, 2, 3, 4, but what we're not really taught and we can't possibly understand is the fourth dimension of things, time, how things heal. Okay. You only get that through experience. And I will say that, like these two gents, I'm constantly reevaluating the things I do to try to make them better. And there are things we notice about the human body that we don't necessarily pick up on early in our training that, oh, wow, the abdomen always falls in a certain way when I do this, right? And so that's just keeping in mind exactly what you're doing. And belly buttons are exactly like that. So early on, the cookie cutter operation for a belly button was you just cut a simple round or oval hole and stick it in. But to me, that doesn't really look like a belly button, right? And I think the understanding of that is you have to understand how scars heal, particularly circular scars. If I have a scar that's this long, okay, and I come back 6 months later, that scar is going to be shorter. So if I convert that line into a circle like this, what's going to happen in 6 months is that scar is going to shrink down, and that creates a very tight and very constricted belly button. But if you look at a good-looking belly button, where is it tight and constricted? It's tight and constricted over the upper pole. The bottom portion is really nice and smooth. So when I do a closure for a belly button, I actually make the top very round and sharp, and then the bottom I convert into a little zigzag or a little chevron with the idea of that'll break up the scar down below. It'll create a nice contour, a nice flow. We have a little bit of excess tissue on the bottom, and I want a nice slope to that. I want it to be a little bit hooded and tight at the top of the belly button. And that's just something I've picked up with time. And I think it just evaluating your technique and trying to improve this over time just helps.
Listening to you, I really enjoy these talks for one thing, is that we all have done these procedures many times and we all get good results. But what separates good results from next level results are all the little things I hear from you guys. So when Sam in Dallas is talking about doing the sutures at the different o'clock positions, or Sal's talking about, shading the abdominal contour to get a more natural, flow to it. Those are the next level things that I love hearing about, because that is what makes a good operation into an amazing operation.
Well, thank you, Dr. Rhee.
Yeah.
Well, let's go ahead and look at this patient's post-op results. This is actually a very early post-operative result, and I'm actually intentionally showing an early post-operative result just so patients can get an idea of what we talk about when we say patients have swelling. So this is a patient that's actually on the left, you're looking at pre-op, and on the right, you're looking at post-op about 6 weeks out from surgery. And what do you see? Well, you basically see that there's still some swelling across the lower abdomen. There's swelling across the upper abdomen as well. I use progressive tension sutures, not only where Dr. Pacella was talking in the midline here, but also across the side to try to create some oblique definition as well. You get an idea of what the belly button looks like early on. It's sort of a narrow slit. And you see how we hide the scar. We're hiding the scar super low. So it's going to be hidden in the pubic region, coming across the junction of the upper thigh and the lower abdomen. In the next view, I actually am trying to demonstrate what we were talking about the bikini line. We really want to be able to hide that scar and camouflage that scar so that you can actually see patients being able to go to the beach, being able to go to the pool, and not show the sequelae of having had a tummy tuck. And then when you look at alternate views, this is what we're talking about in terms of, I'll tell my patients you can expect to have swellings for 6 months to 9 months after surgery. And this is what we're talking about. Even 6 weeks after surgery, you can see she has a little bit of a pooch here, but she looks amazing, right? I mean, the change between pre and post-op is remarkable, but there's still some degree of swelling.
Right. And I think, the thing I really like about this result here is you didn't just concentrate on the front of the abdomen. I will bet that this patient came to see you and chatted with you about her tummy and probably mentioned very little about her lower back area, the fat rolls around her lower back. And I imagine, just looking at this result here, you did some liposuction on the lower back here. And so what you did really well is keep in mind that this is a 360-degree rejuvenation. She's only going to see the front of herself looking straight on in a mirror, but you're gonna have to turn to the side to look at the back, and just getting that whole hourglass shape, I think, is really, really important. So those two operations, liposuction and abdominoplasty, are yin and yang.
That's a very good point. Pretty much every patient. It's interesting. Patients will ask me, is it extra to get liposuction done at the time of my tummy tuck? And I'll tell them all, liposuction is part of your tummy tuck. I don't separate out liposuction at all, but about 1 or 2% of my patients who legitimately have no fat. But lipo 360 of the back, the flanks, the tummy is a huge part of doing a tummy tuck.
Yeah. And patients don't often realize it, but they will after the procedure. Trust me, that's very important.
So you got to get rid of the muffin top.
That love handle area, absolutely.
Yeah, and if you go back to this diagram too, part of the thing that hopefully you can realize is as you come out to the side here, you're not getting out as much skin as you are centrally here. So you really need to do that aggressive liposuction on the back and the flanks for the reasons Dr. Pacella and San Diego mentioned. Skin is tighter. You can remove fat there and expect the skin to tighten down, where essentially you have to excise this greater amount. But if you leave out the liposuction along the flanks and the back, you're not going to get that whole recontouring of the entire silhouette. So
great result.
Yeah,
great result.
Nice.
Thank you, gentlemen. So let's see if we can stop sharing.
We're good.
Good. Perfect. So that gets us right along our 30 minutes that we're trying to stick to. Is there any last thoughts that you guys have about tummy tuck or anything you want patients to come away with after today's show?
I thought that was an awesome result. That was, it sort of showed and highlighted the things that are so important in order to get a great result, which is placement of the incision, contouring, thinking of these things. And this is why you need a surgeon, regardless of where you are in the country, be it West Coast, Texas, East Coast, that anticipates these things for you, because a lot of these patients will not necessarily ask or think to inquire about all of these things. And if you have an experienced surgeon like Sam, they're going to tell you exactly what you will need in order to get something like that. This is what they envision, but a lot of patients don't actually know enough to be able to ask for it. If you only provide what they want, not what they want, what they ask for, but not exactly encompass the entire concept of what an abdominoplasty really means, you'll only get a half measure.
Yeah. Dr. Pacella, any last words?
No, I think it's great. I think, tummy tucks in general, I think our patients are are probably the population that's the most satisfied with their choice of cosmetic surgery. It's just a phenomenal operation that does amazing things, and patients are very, very happy with them. So
yeah, just to echo what these gentlemen say, tummy tucks are one of the most common operations that we do. But Dr. Rhee in New Jersey, Dr. Pacella in San Diego know the little variations that we need to get top-notch results. So with that, we'll call our show to an end, and looking forward to seeing everybody next week.
Great. Thanks again.
All right. Take care, gents.
Take care.